thank you for inviting me to speak, and I guess it's my bio is a little bit historical. We're having worked for many years at the REPAT, which formally closed just 2 days ago, or 3 days ago. So, and I saw the REPAT insignia came up on the closed loop trial, so we're not working out of REPAT anymore. Our research arm is based at Marion GP+. So if any of you are interested in being involved in any of the research that we're doing, we can offer you some diabetes care, a swim at the swimming centre with Kyle Chalmers across the road, and you can do your Christmas shopping at all on the one visit. So we aim to please. So they are my disclosures. So I'm just going to show some pictures of some of my favourite people with type 1 diabetes, other than your good selves. I don't have photos of all of you, so I couldn't put you all up, but just to show that there's a lot of high-achieving, very successful people with type 1 diabetes. You would virtually all recognise these people, Hale Berry and Sharon Stone, sort of well-known actresses, and very appropriate for the theme for today. So I'm going to talk about a variety of the research that we're involved in, and touch on a little bit of research that's come out recently done by other people. And just quickly to talk about our role in the closed loop project. We are the adult site for South Australia. The adult group is 25 years plus. And the Women's and Children's Hospital is running a very similar trial in the paediatric age group, but up to the age of 21. So there is a gap between 21 and 25 where unfortunately people can't get into this particular closed loop trial. But that's the reality, and it is a very exciting project, as David spoke to you about. So one of the things which is happening in sort of diabetes care is the new types of insulins are being developed. There are limitations in the way that the current insulins do work. Even in the best circumstances, there's an up to 20% difference from day to day in the absorption of subcutaneous insulins, even with perfect sort of insulin injection technique. So, and the profile of the insulins don't necessarily match the way insulin would be produced by your body. So, normal insulin production schematically, as David showed in the original talk, is that about 50% of the body's normal insulin production is produced as small amounts continuously when you're not eating, so-called basal insulin, and then the body produces a spike or burst of insulin whenever you eat, and this is what's called prandial insulin. So we can try to reproduce sort of the basal insulin production with long-acting insulins, and the commonly used ones now are Lantus and Levemir and insulins like this. And they don't produce that schematic straight line like that. They produce wiggly lines and different lines from one day to the next. There are new basal insulins that are available in some parts of the world and are also being developed. We've been involved with some of these trials with these new insulins. They're probably not major step forwards from the insulins that we have, so I'm not going to talk at any length about basal insulins tonight. But prandial insulin, as David also mentioned, is something which is being developed and worked on, and the prandial or quick-acting insulins are becoming faster and faster acting. It's been about 20 to 30 years since the so-called insulin analogues, sort of Humalog, Novorapid, Epidra, have come on the market, and they've certainly improved diabetes care through getting closer to normal insulin production. But if you look at this profile here, you can see that what we can achieve with those insulins is not the same. It doesn't produce the very marked rapid peak that you get from natural insulin production, and you get this period where you get too much insulin a few hours after you've eaten. So the best available prandial insulins now are still not perfect. So ultra-fast acting insulins are being developed, and there's a whole range of technologies which are being used to make the insulin absorption even faster, and I won't go into all of these in any great depth, but we're working with one using this combination of chemicals added to a traditional Lispro type insulin. Treprostinil is a a compound which has been used therapeutically as what's called a vasodilator. It opens up blood vessels, and when it's injected with the insulin, it opens up the local blood vessels around the insulin injection and allows more rapid absorption through those dilated blood vessels. And citrate is a compound which increases the leakiness or permeability of the tiny blood vessels called capillaries. So again, the insulin can be absorbed more rapidly. And using a combination of these two therapies, and it's a tiny, tiny amount, so you can't actually detect either of these in your blood after injections with this type of therapy, but locally it does increase the speed of the insulin absorption. So, and this is the sort of difference that you can see. So the orange line is traditional ultra short acting insulin, and the blue line is this new investigational therapy, and you can see that it comes on more rapidly, has a more defined early peak, and then goes away more rapidly. And if you blow up the first, this is over a sort of 6-hour period, if you blow up the first hour, the investigational compound, you can see, has a peak around 20 minutes earlier than the currently available types of insulins, and mimics natural insulin production with meals more closely. So what are the potential benefits of this type of insulin over the insulins we have available now? So most people do have high glucose levels after meals, even with the best carbohydrate counting and the best will in the world. It's very difficult to block that immediate rise in blood sugar straight after a meal. And we're hopeful, I guess, that this type of insulin will control that rise better than the current insulins because of the shorter action overall and less insulin occurring a few hours after the meal. We're hoping that there'll be less hypoglycemia between meals in that sort of 2 to 3 hour period after you've eaten. There's probably going to be more flexibility available in time of administration of the insulin in relation to meals. So it may well be possible to give the insulin halfway through a meal or at the end of a meal and still get very good results because of the very quick acting nature of and the trial that we're involved in involves people giving the insulin immediately before a meal, which is the traditional time, but also a group of people giving it 20 minutes after that, so deliberately giving it well after the meal has been started, and we'll be comparing the results with all of those groups. People will often give extra insulin to deal with post-meal rises in blood sugar, and that can result in what's called stacking of insulin, where you have 2 doses working at the same time. But if you control that rise better, and people will be less inclined to do that, and also there will be less potential for crossover of insulin from 2 doses. So the potential for stacking of insulin doses will be less, and particularly exciting, we think, in use in insulin pumps, where that problem in the lag between the glucose levels being measured and the time it takes to adjust for that with pump adjustments will be reduced by these newer types of insulin. So none of these benefits have been proven, but these trials are going on to try and determine whether they are a reality. So these are my next type 1 diabetic stars. Now I'll go over to this side as well. So I'm rotating my sights, you see how I do this. So this is, of course, Theresa May, the Prime Minister of the UK. She was quite a late onset diagnosis of type 1 diabetes. She's had type 1 diabetes for about 5 years, and obviously hasn't held her back. I sort of put these two people up because these are both Brits because of the upcoming Ashes, and we've got to know our opposition. But then I realised that most of our politicians are actually British citizens too, so the line gets a bit blurred, I think. This gentleman is a little less recognisable, although he shouldn't be. This is Sir Stephen Redgrave, who is the only Olympian to have won gold medals in 5 consecutive Olympics. He developed diabetes, I think, after the 3rd lot of Olympics. He certainly won the last 1 or 2 Olympic gold medals as a type 1 diabetic. So he's an amazing man. So the next thing I'm going to talk about are oral therapies which may be addable to insulin to improve insulin response and have potentially some other benefits. So this concept has been around for quite some time, and I guess Metformin is a drug that's been used in type 2 diabetes and is really the mainstay of therapy in type 2 diabetes, and it seems to have quite a few benefits and probably an increasing range of benefits. And we think of type 1 diabetes as a problem of pure insulin deficiency, but in fact there are some reasons to think that metformin may be quite useful in type 1 diabetes. With the change in the proportions of the whole population, we're seeing an increasing proportion of people with type 1 diabetes who are overweight or at least resistant to insulin and not responding as well to the insulin that they inject. And many patients with type 1 diabetes do actually maintain some insulin secretion for many years, and this has really only become apparent, I guess, in the last 5 or 10 years when we've had very sensitive assays for insulin. We can see that people who have had type 1 diabetes for quite a long period of time actually still make a bit of their own insulin. And we think that we can actually make the most of this sometimes by adding metformin to it. Type 2 diabetes is a very common condition, and the genes for type 2 diabetes are exceedingly common, and many people who have type 1 diabetes also have some of the genes for type 2 diabetes. So if they hadn't developed type 1, they may well have developed type 2 diabetes later on in life. So you don't lose that genetic makeup by developing type 1 diabetes, and so some people are living with aspects of type 1 and type 2 diabetes, and these people may actually benefit from this common treatment for type 2 diabetes. And look, there's been a lot of hoo-ha about metformin being put in the drinking water in recent years because there's been some anti-cancer effects and vascular effects of metformin. A lot of this is hype. I don't think metformin's going to save our power problems in South Australia or bring world peace, but it has been fated as doing some of these things. So people have got very interested in using metformin in a whole range of situations. But I guess the studies of metformin use have been a little disappointing. They have shown some improvements in glucose control with HbA1c, certainly a reduction in insulin requirement, small reduction in weight in some studies, and some improvement in lipids, but reasonably sort of small changes. Probably it's more effective in groups of people who have high insulin requirements, a strong family history of type 2 diabetes, some other features of type 2 diabetes, and particularly with poor glycemic control. And recently a major international study came out looking at metformin use in type 1 diabetes, looking particularly at the vascular effects of type 2 diabetes, and this was of metformin, and this was called the removal study. And it did show a small change in vascular plaque, so this was looking really at the amount of atherosclerosis that was measurable in people's carotid arteries. It was very, very small change in that with metformin use, but there were also some small benefits in weight, insulin requirement, and perhaps some preservation of renal function. So there may be more to the metformin story. It's certainly not a standard treatment for people with type 1 diabetes at the moment, but it is being increasingly looked at. So I'll now move on to another area of sort of drug therapy, which has been quite revolutionary in type 2 diabetes. And this relates to therapies which work through the kidneys to actually increase urinary glucose output. These are called SGLT2 inhibitors. Now this is a photo of me when I was a young consultant with my students here bringing glucose vessels to me in the clinic, and of course the detection of glucose in the urine in those days was really a therapeutic failure, that the people who were really controlling the diabetes very well had no glucose in their urine. But these therapies have actually turned that concept on the head, where glucose in the urine may actually be an important therapeutic outcome. So I'll just talk a bit generally about how glucose is handled in normal circumstances. So obviously we have glucose intake from the diet, and that's very variable how much glucose people take in, but this is just an average. So here I've got 180 grams a day, and the body also makes glucose itself, and you see this yourself if you haven't given enough insulin or you've missed a dose of insulin, your glucose level goes up through the night, and that's the body making its own glucose through these processes, gluconeogenesis and glycogenolysis. So that's the sources of glucose, and all of that glucose goes through your bloodstream and goes into your kidneys. Around 250 grams of glucose is used up through the brain and the rest of the body. But all of this glucose going through the kidneys goes through the filtering apparatus called the glomerulus, and then is reabsorbed within the kidney by these enzymes called SGLT2. So these are very effective enzymes in maintaining glucose within your body. And your bodies, we've developed this system to keep glucose within our body basically because our genes were developed in times when food was scarce, and every calorie that we could get our hands on we wanted to keep and not pass out in our urine. So that is why we developed this system of reabsorbing glucose in the kidney. And this just shows that the glucose goes through the glomerulus in the kidney, which is the filtering apparatus, and goes through this tubule where a variety of things are exchanged. Glucose is actively reabsorbed, so that in a person without diabetes, essentially all the glucose is reabsorbed and none of it goes out in the urine. And the main player in this is this enzyme SGLT2. So there are other SGLTs in other parts of the body, which I won't go into any great depth, but this is an emerging field, and particularly I'll just mention SGLT1 because there are also therapies being developed which also inhibit this enzyme. And this is an enzyme which helps with glucose absorption in the bowel, so it has some role in glucose metabolism within the body. All right, so the history of this type of treatment goes back to 1835 when French chemists found this, the bark of the apple tree actually had effects in producing glucose in the urine. And it was many, many years later before it was found that this compound called florazin actually worked on this system, and it inhibits the enzyme SGLT2 in the kidney, but also SGLT1 in the bowel. So there's a natural inhibitor of this enzyme in nature. And there's also a natural, model of what happens when somebody doesn't have this enzyme throughout their life. There's this condition where people don't have this enzyme from birth, and they pass a lot of sugar out in their urine because they don't have the enzyme reabsorbing the sugar. And they were, in the past, sometimes diagnosed with diabetes because of the sugar in their urine, but their blood sugar is always normal. And in fact, they live without this enzyme for their whole life, and it has no adverse effect on their health at all. So this is a very reassuring natural model that if you inhibit this enzyme in humans, that it's not likely to have very dramatic bad effects. So, as a result, therapies have been developed which are very specific in inhibiting this enzyme SGLT2, and they've been mainly used in type 2 diabetes. And this is a summary of a lot of research, but they show quite a significant reduction in glucose levels because you're passing out so much sugar in your urine that the blood glucose levels drop. If you are requiring insulin for type 2 diabetes, you need less insulin to control your blood sugar, but you still get this lower HbA1c. Because you're passing out a lot of glucose in your urine, you're getting rid of calories. So there's usually weight loss. And because of the effects within the kidney, it also drops your blood pressure about as much as a standard antihypertensive drug would. So these are all, potentially very useful effects. They're generally well-tolerated drugs. Because you're passing out extra sugar in the urine, if you're prone to thrush, genital thrush, then that is a problem. That is certainly a definite side effect of this type of treatment. There's probably a small increase in urinary tract infections, and people need to drink more fluid to avoid dehydration because they're passing out extra sugar and passing out extra urine. But very excitingly, in type 2 diabetes, in the last 2 to 3 years, they've been shown to almost certainly protect kidney function long term, and also quite dramatically reduce death rates and cardiovascular events and heart failure and people going into hospital because of cardiovascular problems if they have established cardiovascular disease. So this is the first time we've had a therapy which has been able to have such dramatic effects within a relatively short period of time. And this in type 2 diabetes, this has been shown within 6 months of starting to take the drug. So they work very quickly and have quite marked effects in very important parameters. So this is a real game changer in type 2 diabetes. But importantly, they are not approved in Australia or any part of the world for that matter for type 1 diabetes, because there have been cases of ketoacidosis associated with this type of treatment. And this, as I say, these drugs have mainly been used in people with type 2 diabetes where the background rate of ketoacidosis is low, but it does exist. And there's been a moderate number of cases and more since then. And the tricky thing about this is that these cases of ketoacidosis have generally not always been associated with extremely high blood sugar levels. So detection of this has been a bit of a problem. And only about 50% of them had the standard triggers that people with type 1 diabetes would expect to get ketoacidosis with. So I think it is generally accepted that these drugs do increase the risk of ketoacidosis, and that is the reason that they're not approved for use in type 1 diabetes yet. And that's just a bit of an idea of the mechanism. So often people reduce their doses of insulin. That's part of the therapeutic effect. They might get dehydrated, and for a variety of reasons, glucagon levels go up. And the net result of all of that can be that you can get more ketones and a risk of ketoacidosis as a result. But, being brave investigators, people have still looked at these therapies in type 1 diabetes, and so a few years ago we started to see very small pilot studies coming out looking at small groups of people with type 1 diabetes treated with these therapies, because they certainly work in lowering glucose levels in the same way as they work in type 2 diabetes. And this was the first study that I saw where looking really at 2 weeks of treatment just to see that it proved that people did lower their glucose levels, and even in that space of time lost some weight. So we've been involved in sort of longer term studies looking at SGLT2 therapy in type 1 diabetes, and this study we finished about 6 months ago and got published in the Lancet earlier this year, in fact in September. And this was really looking at using one of these drugs for a 6-month period in people with type 1 diabetes. And what did it show? So this was the drug. There was 2 different doses used, and the primary outcome was change in HbA1c. These were adults aged 18 to 75, and we were one of the sites, and I think David was also one of the sites for this study. So just running you through this, both doses of the drug did result in lower HbA1c by about 0.4 to 0.5%, which is quite a meaningful reduction over that period of time. Around a 3% reduction in weight. Insulin doses were reduced by about 10%, and if you believe that an ideal glucose level is, say, between 4 and 10, the time that people spent in that ideal range was increased by 2 to 2.5 hours in a 24-hour period. And these people had CGMS and other tests to prove that. So people spent more time within the ideal glucose range, the HbA1c was lower, and they lost some weight. So all desirable outcomes and all quite significant in terms of statistics. In terms of adverse effects, hypoglycemia was not significantly different in the treated groups versus the placebo group. So if you adjust the doses of insulin appropriately, then you don't necessarily increase hypoglycemia. There was perhaps a slight increase in urinary tract infections, but not dramatic. And ketoacidosis, fortunately, was not dramatically different between the two groups. So, I mean, this demonstrated, I think, because people looked very closely for ketones in this study, and I think it's very important that that was very closely examined, because it is at least a theoretical significant problem in type 1 diabetes. So at the same time, another study using a different compound but of the same type came out, and it also showed very similar results. So we have two studies, both working over 6 months. This was called the Tandem 3 study, using a medication called sotagliflozin, which is an SGLT1 and 2 inhibitor. But just to this is the HbA1c difference, and it showed very similar reduction in HbA1c, around a 0.4 to 0.5% reduction which was maintained over 6 months. So quite similar results. So this is me driving home after this, trying to balance the sort of positive effects of SGLT2 therapy for people with type 1 diabetes with the dangers, and not an easy job. So at the moment, despite this evidence, SGLT2 therapy is not recommended as a standard treatment. It's not TGA approved in Australia, but my gut feeling will be that over the coming years it will be, and there probably will be a role for this as a therapy, particularly if some of the longer term effects, the cardiac and the renal effects, are also proven in type 1 diabetes, because that will sway the balance well towards benefit, I think. So they're just the three SGLT2 inhibitors that are available worldwide. Canagliflozin is not available in Australia for complex reasons, but dapagliflozin and empagliflozin are. Okay, so the next thing I'll just talk about briefly is medications to reduce progression of complications. And so we're doing a study using a medication called Fenofibrate, marketed in Australia as Lipidil, for diabetic retinopathy. And why are we doing that? Fenofibrate is primarily being used to treat lipid disorders. It's been around for a long time, 25 years or so. We know what it does well. It reduces triglycerides and increases the good cholesterol, HDL cholesterol. So back in the 90s in Australia, New Zealand and Finland, a study called the Field Study was done to look at Fenofibrate and its effects on cardiovascular complications. And it was a bit disappointing in that it didn't make a lot of difference apart from to a small subgroup of patients. But fortunately, they also looked at other diabetic complications in this study and actually showed a reduction in amputations, eye complications and kidney complications in people taking Fenofibrate. And specifically with eye complications, there was a 37% less need for laser and progression of people of diabetic retinopathy. Importantly, the reduction in risk was only shown in people who had some degree of retinopathy at baseline. So if you had no retinopathy at the start of the study, then you didn't seem to benefit. And then this was probably not given the, publicity that it should have, until a second study came out around 10 years ago, which was called the Accord Eye study, which again looked at this same therapy and showed incredibly similar results, around a 35 to 40% reduction in progression of retinopathy. So we do think this is real. Fenofibrate is readily available in Australia and commonly recommended for people with type 2 diabetes and retinopathy, because all of these studies were done in people with type 2 diabetes, not in type 1. So it's not sort of recommended or approved for use in type 1 diabetes as yet, but its mechanism of action would suggest that it's likely to be of benefit for people with type 1 diabetes also. So it's a cheap drug, it's generally well tolerated, occasionally it has some muscle side effects, but it can be safely used with statins, the common cholesterol lowering therapies. So it's a pretty clean drug, and so we're involved in NHMRC and JDRF sponsored trial looking at this therapy in type 1 diabetes. And this is the first time this study has been done worldwide. It's been run in Australia and New Zealand. And it's a very simple study. Basically, it's the standard dose of the drug versus a placebo or a dummy tablet daily for 3 years. You need to have type 1 diabetes diagnosed before the age of 40, and you need to have some retinopathy, mild to moderate at baseline. You're not allowed to have immediate laser or cataract surgery in the next 6 months. It's not many visits. It's a yearly eye test, and we're measuring not only the progression of the eye problems, but also some of the other diabetic complications which may also be benefited by this therapy. Okay, a couple more of my favourite type 1 diabetics. This is, of course, Wasim Akram, one of the greatest cricketers of all time, incredibly talented man, could do everything. Played virtually his whole career with type 1 diabetes, and you can imagine playing cricket in Pakistan and places like that. It's incredibly playing 7 hours out in a 40-degree subcontinental day. He was amazing to be able to play at the level that he did. And Nathan Bassett, who you all know locally, been a great ambassador for type 1 diabetes within our state, and diagnosed just as he started his AFL career and played throughout. And I think the only mishap he had was when I changed his insulin once and he fell over at training, but that was otherwise he was incredible. He looked after himself brilliantly, so I take the responsibility for that. So immune therapy to preserve pancreatic beta cell function. So as David mentioned, the beta cells are the key to insulin production, and unfortunately by the time people present with type 1 diabetes, they've usually lost around 70 to 80% of the function of their beta cells in terms of insulin production. Now, anything which preserves that remaining ability to make insulin actually makes it easier to control people's diabetes. And those of you who have had diabetes, type 1 diabetes, may have got into what's called a honeymoon phase, where you have some recovery of insulin production and a period where you can relatively easily control the diabetes on relatively small doses of insulin. So I guess the theory of this type of treatment is not to bring back all of the beta cell function, because you can't generally recover what's already been lost, but to preserve what you do have when you present, and to extend the period of time that the beta cells do work for, so that the diabetes is often significantly easier to control with less risk of complications in the long term. So this is fairly complex stuff, so I'll just give but basically the therapy that we're working with is actually a treatment against a virally encoded piece of DNA which has been incorporated into human DNA over many, many generations ago. And in fact, about 10% of human DNA has come from viral origin. And some of this DNA seems to be inert and doesn't do very much. Some of it gets activated in situations of stress or other things happening like various infections. And this particular protein was first discovered in people suffering from multiple sclerosis, and it was called multiple sclerosis related viral protein as a result. And most of the work with this particular treatment has been so far in multiple sclerosis, because that was where it was first detected. Multiple sclerosis is an autoimmune condition analogous to type 1 diabetes. So fortunately, when they were doing the initial studies for multiple sclerosis patients, they needed some what's called controls. So they looked at some other people, and they looked at people who had other autoimmune conditions. And they found that people with type 1 diabetes had much higher levels of this MSREV envelope, which is the protein made by this viral DNA, in both French and so did. So two different groups of people both had significantly more of this protein than people who didn't have type 1 diabetes or other autoimmune conditions. And then they thought this is interesting, so they actually looked in the pancreatic biopsies of people with type 1 diabetes who had these for one reason or another. There's a store of these throughout the world, and found that in fact this protein was also expressed in the pancreas, and particularly in the beta cells of people with type 1 diabetes. And then they went back to animal models and looked at type 1 diabetes in animals and found that the same thing occurred in some animals, and if you injected this protein into the pancreases of animals, that they developed type 1 diabetes. So this protein seems to be, in fact, deleterious, or it destroys some of the beta cells and actually reduces the amount of insulin that people can make. And this was something done subsequently in humans. So they gave various doses of this protein to the cells of people with type 1 diabetes, and this protein inhibited the amount of insulin that these cells could make. So all of this suggested that this protein has a potential role as a mediator of some of the damage in the beta cells in type 1 diabetes. So a variety of lines of evidence. It also, if you inject this protein, it produces inflammation and the sorts of histological changes that you see in the pancreas in type 1 diabetes. So the rationale for trying this treatment in type 1 diabetes is, summarised on the previous slides as higher levels of the biomarkers in people with type 1 diabetes. Up to 75% of diabetic pancreases express this protein, and when you give this protein, it inhibits human insulin production. So an antibody to this protein was developed, which is a very specific antibody. It binds purely to this protein and doesn't bind to other proteins or elements in the human body. And this is basically in a multiple sclerosis patient. So if you give this antibody, it shows that the amount of this protein progressively reduces. So you can get rid of this protein, or at least reduce the amount of protein, by giving this antibody, this immunological treatment. And in terms of safety, most of the work so far has been done in multiple sclerosis patients, and they have found very few side effects, fortunately. It does seem to have been very well tolerated using the sorts of regimens that we're using in this study, so monthly infusions over 6 months. And it stabilised the multiple sclerosis manifestations, at least, so that none of their multiple sclerosis patients progressed to more severe disease. So this is the name of the study that we're involved in, using this antibody to try and neutralise this protein. That's sort of talked about the rationale. So the main aim of the study is to assess the safety and tolerability of this regimen, because this is the first study in the world looking at this treatment in people with type 1 diabetes, sort of actually giving it to real people, whole people with the condition. So safety is the first thing, but we're also looking at a variety of parameters: how much insulin you can make, what the inflammatory parameters in the bloodstream look like, to see if there seems to be a response in terms of maintenance of insulin secretion, which is the key thing, I guess, we're hoping to show. You need to be between the ages of 18, it's now 50, there's been an amendment, so you need to have had diabetes diagnosed in the last 4 years, because I guess we're looking to preserve the beta cell function. If people have had diabetes for more than 4 years, it's unlikely that we're going to be able to preserve a lot of function. So that's the group that we're looking at in this particular study. And I'll finish there.